I'd like to welcome you to our ILCN Multidisciplinary Forum, Molecular Challenges. Today, we're going to be talking about understanding treatment options and resistance in EGFR-positive non-small cell lung cancer. I'm Dr. Karen Reckamp, the Director of the Division of Medical Oncology at Cedars-Sinai Cancer and the Associate Director for Clinical Research in Los Angeles, California. And here are my disclosures. Next on our panel is Sarah Christ, who will introduce herself.
Hi, my name is Sarah Christ. I'm a member of the EGFR Resistors Patient Advocacy Group. I am a lung cancer patient diagnosed in 2016 with stage 4 non-small cell EGFR-positive lung cancer with metastases to the brain and liver. I am now thriving on targeted therapy, 3 years on the same drug after some progression on my initial treatment.
And Dr. Ibiaya Dagogo-Jack.
Hi, everyone. My name is Ibiaya Dagogo-Jack. I'm a thoracic oncologist at Mass General Hospital at Harvard Medical School. And these are my disclosures.
Dr. Ticiana Leal.
Hi, everyone. Thank you very much for inviting me to be here today. I'm a medical thoracic oncology specialist at the University of Wisconsin at the Carbone Cancer Center in Madison, Wisconsin. I look forward to the discussion today.
And Dr. Daniel S.W. Tan.
Hi, everyone. I'm a medical oncologist based out in Singapore. I'm again happy to be with everyone today to discuss this important topic.
Thank you. Glad to have everybody here today. We'll be talking about a case that is based on EGFR mutant non-small cell lung cancer, talk about initial diagnosis and the development of progression and resistance that occurs. We'll start with our case. This is a 57-year-old non-smoking female without significant past medical history who presented in 2017, initially with left-sided chest pain and a progressive dry cough. Her symptoms worsened after several courses of antibiotics, and a chest x-ray was performed, which showed a left upper lobe density. A CT of the chest then demonstrated a 7.4 centimeter left upper lobe mass with bilateral pleural effusions and pericardial effusion. There were prominent mediastinal lymph nodes. PET CT confirmed uptake in the left lung, pleura, and mediastinal lymph nodes. And the left axillary lymph node biopsy revealed adenocarcinoma with immunohistochemistry demonstrating TTF1 and NAPSIN8 positive. PD-L1 tumor proportion score was 80%. And next generation sequencing was pending. And at that time, an MRI of the brain was performed. These are some baseline scans showing representation of some of the disease, the left axillary lymph node and left lung mass and pleural masses. Bringing this to our panel, Ticiana, do you want to discuss the importance of comprehensive genomic testing at the time of non-small cell lung cancer diagnosis?
Yeah, definitely. I think this is standard to perform comprehensive genomic testing at initial diagnosis of all patients with non-squamous non-small cell lung cancer. This is something that ideally we should be performing this on tissue. Also, increasingly, we're performing this on plasma as well. Based on NCCN guidelines, tissue is still gold standard, with plasma being done if there is inadequate tissue. We have seen results of the NILE study, which was a prospective study that actually looked at NGS being performed in plasma as well as in tissue, which actually showed that there was non-inferiority in identifying results that were actionable both in plasma as well as in tissue with good concordance. And one of the advantages of liquid is that you get really rapid turnaround time. So the answer is very important to do upfront and very important to do a broad panel upfront as well. Tissue preferred, but I think increasingly in my own practice, I do incorporate NGS using plasma-based testing as well.
Thank you. And Daniel, do you want to provide a kind of a worldview on NGS testing in Asia and Singapore specifically?
Yeah, no, I mean, I think it's always an important consideration about what, the population prevalence is of certain types of drivers as well. While there are increasingly number of actionable alterations that admittedly would be very nicely broadly captured with these comprehensive genomic panels, depending on resource availability in certain areas in the world where there's higher prevalence, for example, of EGFR. There was a recent abstract that was presented at WCLC that was suggesting that it may also be viable strategy in terms of the societal cost to screen initially for EGFR upfront, with subsequent comprehensive genomic profiling should that be negative. I think some of the prior data were in the context of screening upfront for KRAS, which I appreciate was previously one of the exclusionary kind of factors that you would test for first as an initial driver. So I think there are some considerations there with regards to how we can deploy this. But again, I think this is going to be something that over time, as sequencing costs come down, perhaps will be less of an issue. But in general, I think it's important that we do make these important investigations upfront or as early as possible in the patient's journey.
Great, thank you. And Sarah, can you comment on the importance of comprehensive testing prior to starting therapy from a patient perspective?
Absolutely. When I was on first diagnosis, my tumor was sent out for testing. However, the results were not back for about 2 months. I was rushed into chemotherapy pretty much within the first week, without waiting for those results. And on further, looking back over time, there was some error that took place because the results were in fact back in a week. So I tell anyone who's a newly diagnosed patient that that's something that you need to not only press for the testing, but press for the results to come back in a timely manner, because it does not take 2 months, which I know now with hindsight.
That's an excellent point. Being your own advocate is incredibly important at certain times in the treatment process. And these points about doing NGS testing up front, I think are incredibly important and need to be understood. And in the context of PD-L1 testing, we get that back relatively quickly. And this patient had an elevated PD-L1 expression. Ibiaya, how do you think about patients who have high PD-L1 expression and starting treatment when they hear, great, I can start immunotherapy? How do you balance this with the patient?
I think it's a very, very good question, right? There's definitely a tension with a new diagnosis to start a treatment, but I think that we have to always give the best treatment and the treatment that's most likely to have the most success. And so as Sarah mentioned, it's very important for us to try to speed up our molecular testing as best as we can. But we also have learned over the years that PD-L1 is not the same for every single patient, the relevance of it as far as treatments. And I know that we're highlighting PD-L1, having high PD-L1 expression, and just to take a step back, the reason that matters is that we now have several trials that have demonstrated that for most patients, you do better with immunotherapy, both kind of pembrolizumab, cemiplimab, and atezolizumab in the United States have been kind of approved in this setting. But we know that, based on initially retrospective work in now clinical trials, that patients with certain molecular alterations and certain demographic characteristics, like this patient, a never smoker, PD-L1 may not be that predictive of response to therapy. And it may actually be harmful to start with that approach because there may be overlapping toxicities that may preclude the patient from getting a therapy that would be significantly more effective for their cancer. And so I think that while it may be unsettling, it's a better outcome if we wait for the results to come back.
Thank you. I think also important to note that the patient who gets immunotherapy may have higher toxicity if they end up having something like an EGFR mutation and start a drug like osimertinib. And so this patient was getting comprehensive genomic testing and did not start on therapy immediately, but did have an MRI of the brain. And here we see the patient had multifocal brain metastases, multiple small metastases throughout the brain. And the initial recommendation to this patient was to receive whole brain radiation. So we'll stop on this point for a moment here. And I'll start with you on this one, Ibiaya. What do you consider when you're thinking about multifocal brain metastases at the time of initial diagnosis? And you can take either PD-L1 or EGFR or other actionable mutation when you're thinking about this.
Yeah, I think the first thing I think about is the symptoms. So is it a very symptomatic brain metastasis? We've pointed out that they're multifocal. And so in this case, we probably wouldn't think about a surgical approach, but multifocal brain metastases sometimes can present with a high symptom burden. And then in those cases, I think, unfortunately, while waiting for molecular testing to come back, we may not have the time. And so there, in those cases, we may need to act. But in general, the hope is that in the context of an actionable alteration, and particularly not just an actionable alteration, but one for which there are proof or kind of proven therapies with great blood-brain barrier penetration, my preference has always been to favor the targeted therapy and to spare the radiation, because our hope is that our patients can benefit from these therapies for many, many years. And it'd be ideal to spare the toxicities that come down the line or downstream years later after whole brain radiation therapy.
Thank you. And Sarah, when you're thinking about potentially progression or disease within the brain, that's a scary thing for a patient. How do you think about when you hear about these targeted therapies and how important it is that it has efficacy within the brain?
Extremely important for myself and also for the patient community I'm part of. Whole brain radiation is one of those scary prospects. My mother went through whole brain radiation. She was also a lung cancer patient, and I vividly remember that was the start of a decline in her cognitive abilities. And to me, it would be something I'd want to avoid. I was lucky to have gamma knife radiation to my brain lesions, which left me no ill after effects. But had I been started on targeted therapy from the get-go, I might have been able to avoid that. So the ability to, I mean, radiation has come a long way in the precision targeting, but the idea of having an oral medication take care of your brain mets is far more appealing than strapping on that gamma knife helmet.
I'd say
I
so.
do want to add that that you brought up a very important point, Sarah, and this is an approach that I frequently use with our multi-D team. If there is a patient that has a new diagnosis and has multifocal brain metastasis, we'll frequently have our multidisciplinary team with neurosurgery as well as radiation, where as we're waiting for that panel to come back with their NGS and PD-L1, if there is a larger lesion or if there's a symptom that we can palliate with local therapy to that larger lesion while we wait for the NGS panel and really avoid and delay whole brain, we'll take that approach first and then wait for the NGS panel, the PD-L1, and then decide really what the best approach is to really avoid whole brain radiation up front, which definitely is the best approach.
And I just add on to that, and I do agree that this kind of with all the therapeutic options that we do have now, it's pretty important to be quite thoughtful about how we deploy whole brain radiation as a treatment, given the fact that we do have effective CNS penetrant therapies. And as Ibiaya said, we want to avoid as best as possible some of the medium and longer term effects, and even short term effects of fatigue that can actually influence the initial tolerance to initial therapy.
And I will say you can buy some time with steroids as well. So dexamethasone, depending, can buy you some time as you are trying to figure out the best multi-D approach for a patient with newly diagnosed non-small cell lung cancer with brain mets as well.
And Ticiana, can you comment on patients who have high PD-L1 but might not have actionable mutations and how you might think a little differently about these types of patients?
Yeah, I think in a patient who has high PD-L1 expression, and again, I think it depends on, are they neurologically stable? What is the location of the brain metastatic disease? And also, what is the burden of the brain metastatic disease? I think if you have small brain mets with a relatively, with a location that you've discussed it with neurosurgery and radiation oncology, I have taken the approach of starting PD-1 targeted therapy first with close surveillance of the brain with repeat brain MRI in 6 to 8 weeks. And we have seen responses in the brain. Obviously, that's not a standard approach yet. We've seen, the results of studies showing initial responses of 40% with PD-1 targeted therapy with pembrolizumab, especially in the high PD-L1 population. And so that is an approach that we do in selected patients with close surveillance of the brain, and I have done that before, but I do think that it really requires a very detailed discussion with the patient.
What are the patients who you might think about doing whole brain radiation at the time of initial diagnosis?
I think some of the points have been highlighted here, and I would kind of piggyback off of Daniel and Ticiana and say if someone has a high burden of brain metastasis, and particularly symptomatic brain metastasis, then I would think about upfront local therapy. And if it depends on the location as well. If you have brain metastasis in a location where we think that our treatment options may not be effective or work really quickly and so on, and you worry about that compromising functional status sooner than your medicine can take effect, those are patients I would think about whole brain radiation therapy. I also think that, in my practice, I do consider it, again, going off of the excellent discussion from Ticiana, if someone had a PD-L1 negative tumor and there were really no actionable alterations, I think, that is a context, and the burden, especially if a lot of the burden of disease is in the CNS, and in some cases where we have a context or scenario where a lot of the burden of the disease is in the CNS, and there isn't symptomatic disease outside of the CNS where you can really just focus on the brain. But also, for me, if someone doesn't have an actionable alteration, and I do worry about the morbidity of the progression of the brain metastasis, that might be a context where I consider upfront local therapy.
Absolutely.
And I'll say that we don't have a radiation oncologist here, but some of my radiation oncology colleagues will argue that now that we've kind of pushed back on whole brain radiation, that maybe sometimes we wait too long and patients become too symptomatic before we're willing to even consider it. Daniel, you had a comment.
Yeah, well, I think this, I do agree that having said what, the discussion about being circumspect about how we utilize whole brain radiation there, there does come a point in the treatment history where we may, it is an effective treatment still in terms of controlling brain metastasis. So I think it's just a consideration not to just be too reflexly use it upfront when we first initially encounter a patient with brain metastasis. And I just wanted to make the point that in this risk-benefit ratio, in terms of deciding on whether to go ahead with radiation, the consideration needs to be given to extracranial disease burden as well. So if those patient had symptomatic disease, you may not necessarily want to get them down the route of doing 2 weeks of whole brain radiation, the recovery after that before initiating systemic therapy, because then that can lead to subsequent functional decline and further deterioration as well. So I think that a whole range of different factors that have already been mentioned, including that burden of extracranial disease, that we do need to take into account here.
And Karen, sorry to interrupt. There's a few other contexts things that I neglected to mention. One, I think at least at our institution, age does weigh in. And when we think about whole brain radiation, I think that the cognitive effects of whole brain radiation can be kind of unevenly distributed depending on age. And so if someone is older, kind of in our institution, people older than 70, 75, then we give some serious thought to it because the complications from the therapy could be significant. And I also want to point out that there are techniques that the radiation oncologist can do to preserve some of the memory and cognitive function, including hippocampus sparing radiation. It takes a little bit longer to plan, but it is an option.
Thank you. This was an excellent discussion. So we'll move on with the case now. And NGS did demonstrate a deletion in exon 19 in the EGFR gene and a TP53 mutation. So in this case, we want to think about kind of worldviews, as there are differing worldviews when we think about taking care of, when we think about treating with first-line therapy for EGFR mutant non-small cell lung cancer. So I'll ask Ticiana and Ibiaya to take on kind of the US thought process, and then ask Daniel to give us a Asia worldview thought process on this concept.
Yeah, I would say that in our patient population here, based on the Flora trial, I certainly see most commonly that we use osimertinib up front as monotherapy for our patients with sensitizing EGFR mutations. And certainly that has been demonstrated to have improved overall survival compared to the first generation EGFR TKIs with excellent tolerability, excellent CNS disease control, as well as we saw the PFS results as well as overall survival. So certainly that is the preferred frontline strategy as of now. There are other strategies that are included in the NCCN guidelines, including the other EGFR TKIs are still included in the NCCN guidelines. And we saw the approval of combination strategies of erlotinib with the strategy of adding VEGF inhibition as well. But I think there are challenges with that I will let others also weigh in. But I think one thing that I do want to point out, and we'll discuss that as we talk about resistance, is that there are situations where we don't know up front who's going to do really well on osimertinib monotherapy versus are there patients who do need more than osimertinib monotherapy. And I think that is an important discussion. And as we develop, therapies in the future, I think that's an important topic to discuss.
Yeah, so maybe I can provide the Asian perspective, I suppose. And I do think that this is, we see this in 50-60% of patients, of lung cancer patients. And I think one of the challenges that we have now is, again, even across Asia, that, access to, not all areas have access to all the entire repertoire of EGFR TKIs. So in a way, I think maybe I can start with my own personal practice. Factors that do to come into consideration include for tolerability of patient's age, functional status, as one of the foremost considerations, and their ability to potentially and be prepared for some of the side effects that we know can be associated with some of this class of agents. And previously as well, using features such as presence or absence of brain metastases, that does seem to be factor that weighs into that decision, given the fact that some of the different generations of drugs does have a varying penetration of CNS. There are poorest features as well that sometimes we take into consideration, and features such as prior smoking, presence brain metastasis, those sometimes portend worse outcomes from retrospective series. So I think there's certainly still quite a prevalent practice of using first generation or second generation TKIs up front, going with that sequential approach in the event of development of on target T790M mutation resistance. And though there is concern about possibly some of the CNS penetration in patients who have received first and second generation, it is still possible to get an initial response as well as a durable response to these earlier generation TKIs. But having said that, I think there in the third generation activity probably is the highest from the studies that we've seen so far. And certainly there can be room for that tiered approach. For example, if the initial response was suboptimal, then there would be an opportunity to kind of switch out to a third generation TKI.
And Ibiaya, do you want to talk about some of the combination therapies and kind of pros and cons and your thought process as these move forward?
Yeah, I'm happy to. And so in thinking about the combinations, the one thing I'll say is that a lot of the data that we have with combinations use a backbone of first generation EGFR TKIs or targeted therapies. And so the combination that was mentioned by Ticiana that's approved is the erlotinib ramucirumab combination. And there, I think it's a bit challenging to kind of compare apples to oranges, but there it was approved based on an improvement in overall survival from 12 to 19 months. And I highlight that 19-month number because that's what we see with osimertinib by itself. And so it's quite comparable. The trade-off, and Sarah could probably speak better to this, is that you take a pill with osimertinib versus you take a pill and then you come in every few weeks for an infusion for ramucirumab. And then there's toxicities with ramucirumab that are added to hypertension and other things that you have to monitor for. And so I think that is, in my practice, I don't often use that because, a lot of my patients value kind of the independence, the ability to not come back and forth into the hospital for the therapies. Other combinations that have been explored, again, using a first generation backbone, is the combination of chemo plus an EGFR targeted therapy. Again, we've seen like kind of Japanese studies, and we've also seen the Neurona study that was presented at ASCO a couple of years ago. Here again, the median progression-free survival tends to come in around what we see with osimertinib by itself. It certainly seems to improve compared to just the single agent EGFR TKI by itself. But again, considering the tolerability of osimertinib, the ease of administration, it really hasn't impacted my practice. And the one point I want to make is also that there's been work looking at osimertinib as the backbone in combination with a VEGF-targeted approach. A lot of work led by Helena Yu looking at kind of osimertinib plus Avastin. We've seen early phase 1 and phase 2 data for that. But again, I would look forward to more data using chemo combinations or even VEGF combinations with the osimertinib backbone before changing my practice.
Thank you. And I agree. I mean, part of the reason we are even discussing these aspects are because despite the fact that responses are good, most patients develop resistance and progression. And so we do need something better, and moving that to the front line would be ideal. But right now, still the single agent EGFR TKIs seem to be the most prominent choices, even around the world. Sarah, can you comment on your thoughts when you see some of these combinations coming through?
Sure. Again, from the patient perspective, obviously to wake up in the morning and take a pill in your own bathroom and go about your day is probably the most appealing course of treatment. If that's going to have similar outcomes to being on infusion, I think most patients would say, sure, give me an oral medication that's going to have the same outcome as going for an infusion. What I find among my friends in the lung cancer community, when there is progression on the single agent TKIs, that's when you go to a combination therapy, and we're certainly happy to have them available there. And I fully expect to be back on infusion again someday, but the longer I can put off that day, the better for my own quality of life.
Great, thank you for that perspective. And going back to our case, this patient did go on osimertinib and had excellent response, as we can see from the CT scans, nearly complete response within the lung, within the lymph nodes, and then also, as we see, within the brain. And the maximum response was seen at about 16 weeks and persisted. And as I had mentioned in the beginning, this is a patient who was first diagnosed in 2017. And so did well for a period of time, which is what we expect for patients on osimertinib. So after about 3 years on treatment, she developed some sub-centimeter growth of bilateral pulmonary nodules on the CT scan, with the largest of 6 millimeters, but did not have any symptoms at that time. So this is a patient with possible early progression and on an oral drug that has worked very well, but looks like it may be nearing the end of its valuable time. What would you do for a patient like this with mild but asymptomatic tumor progression on osimertinib? Ibiaya?
I think that it depends on, I think this is a good opportunity actually to discuss kind of early progression and sometimes even introduce the concept of oligo progression. So it really depends on where someone is progressing. Here, it looks like in this patient's case, they're presenting in multiple areas in the lung. And so that can be a little bit challenging in the sense of thinking about doing local approaches like radiation for. But it's beneficial that there aren't any symptoms. And so there is an opportunity to continue treatment beyond progression. And there are some people whose biology of disease is such that they can have very, very slow progression. So you can actually continue the drug for a period of time. I highlight the point that it's in the lung because that does kind of give us some challenges in terms of figuring out what is driving the resistance without doing a direct biopsy, because we would love to do kind of plasma testing or other things, but the sensitivity might be a little lower in this context where when we have thoracic cavity confined progression, it may not shed into the circulation. But in other scenarios, like kind of oligo progression just in an adrenal or in other areas, I have considered local radiation or kind of ablative approaches and then continuing therapy with the premise that there may be an underlying kind of resistant clone that may not have kind of broadly distributed to other sites. And that way we can eliminate that clone and continue to treat the sensitive disease with the same therapy.
Thank you. And Ticiana, can you speak a little bit more to the role of a liquid biopsy at this time?
Yeah, the other thing that I would add too in this patient's case is I would repeat the brain MRI, just kind of looking in terms of what kind of progression this patient is having in terms of the disease to obviously make sure that the brain was still under good control, because that would change obviously the treatment beyond progression approach. But certainly I agree with the concern that given the low volume metastatic progression in this case, that the plasma testing at this point might not capture the mechanism of resistance. So I find it of low value at this point. I think clinically you have to have the discussion with the patient. There's a concern here of early progression. There may be some value of monitoring closely and continuing, although we realize that we are going to have to start planning our next treatment is kind of what we start to talk about. And a lot of times it's a discussion that since this patient is doing well otherwise, is tolerating the treatment, hopefully having good quality of life and doing the things that they need to be doing right now, they are okay with this approach. And so I honestly would save that liquid biopsy test for a little bit later, because I'd worry that I'd have an insurance problem if I use it up now and I'd wait a little bit. So I definitely think there's value. I definitely would use it, but I would probably wait a little bit longer so that I wouldn't run into an insurance problem if I need to do it later. And probably for the time being, treat with OC for a little bit longer.
And Daniel, what are your thoughts on liquid versus tissue biopsy at this time versus holding the course?
So, again, I think this is important with this early progression, that it's certainly a sign for us to perhaps, reduce the intervals between the surveillance scans, and really track that growth trajectory or how this develops, because as had been mentioned before, there are instances where some patients have just very slow progression over a period of time. But it's certainly something to be important to start, initiating that discussion and, perhaps starting to introduce some of these other options, including combinations that, we had discussed earlier as well. I think with regards to liquid biopsy, I do agree that it's a challenge, even in a resource unlimited setting where, you know that the performance is not it's not as good as we would like it to be at this point, particularly with low volume progression. And certainly for these, if there was a single site lesion, I think that the ideal option would be to consider local therapy possibilities, but at the same time try to acquire a sample of the tissue that again can help with future treatment planning in a sense. So I think I agree that with both opinions earlier that at this point in time, at least, it would be reasonable for us to just hold a course and so do perhaps more regular surveillance on imaging.
And Sarah, what goes through your head when you see this mild progression, and what, as we're talking about, we start having discussions about what comes next and what to prepare for? How are you taking this as a patient?
Well, I appreciate what you're all saying about taking the patient's perspective into consideration. Progression is obviously the thing we all expect and yet fear at the same time. I don't think it comes as a tremendous surprise. We're all sort of waiting for that day to come. I think if you were having a asymptomatic minor progression and the doctor's approach was to just monitor ever more closely, that's going to be, rather than jump ship and say, well, we have to just do something, change treatment plan. The idea, it's that there's some comfort to the idea of let's just, kind of close in and watch this really carefully and start planning for the eventuality that we're going to have to change course of treatment.
Thank you. So the patient did have a liquid biopsy, and the result was, as you might guess, negative. So non-diagnostic and probably not shedding enough to determine anything from that liquid biopsy. But as everyone predicted, the patient did start to experience symptoms several months later, increase in dyspnea and cough. And at that time did get a liquid biopsy that showed deletion in exon 19, a C797S, and again, TP53 mutations. Due to potential for clinical trials, the patient also underwent a left axillary lymph node biopsy, which showed the invasive, moderately differentiated adenocarcinoma, and that had the EGFR deletion 19, C797S, and a TERT amplification on NGS. And the scans can be seen here. We see bilateral axillary lymphadenopathy and significant progression within the left lung and pleura. So we're at the point of resistance to osimertinib. And I think this is an important topic, as it is an area where there is no standard of care outside of frontline chemotherapy as standard of care. And even the use of immunotherapy would be, could be debated in this setting. And so if you could discuss some of the mechanisms of resistance to osimertinib, Ibiaya, to help us start the discussion.
So a lot of our initial understanding of resistance to osimertinib came in the context of patients receiving a first-generation EGFR targeted therapy like erlotinib or gefitinib, and then getting osimertinib in the setting of T790M. And that context suggested that, on-target resistance, typically in the form of what this patient has, so the C797S mutation, was present in around 20 to 25% of patients. And then there are kind of rarer other on-target kind of EGFR-acquired mutations. And also in that context, we saw that there are patients who had what we call kind of EGFR-independent resistance mechanisms, like bypass tracks. So MET amplification is one that was described a while back. We see it in around 10 to 15% of patients. We rarely see histologic transformations like small cell transformation, which is why I think it's important that this patient, even though they had a liquid biopsy, they also had a tissue biopsy to confirm that adenocarcinoma was still present. And then we also see kind of rare things like fusions. With the kind of incorporation of osimertinib into the first line setting, we've seen a little bit of a shift in the spectrum of resistance mechanisms, but it's still a bit early. So a lot of what we've seen so far are a few studies with kind of 20 to 30 patients. And what we can't tell is whether we're seeing kind of patients who have earlier progression versus what patients might develop if you looked at a larger cohort that was better representative of all kind of spectrums of progression. But in those studies, we're seeing that the on-target resistance, so the EGFR mutations, aren't as high as 20 to 25%. It's a little bit closer to 5 to 10%. we are still seeing kind of MET amplification at the same type of frequency of kind of 15 to 20%. There was an interesting publication by the Memorial Group that suggested that the histologic switches may be actually more diverse than we'd actually appreciated from earlier generations, where we were really focused on small cell transformation. So there they described squamous transformations, which is something that had been kind of rarely described, but we don't understand a lot about the biology of. And I highlight the kind of the diversity or heterogeneity of resistance mechanisms because it really creates a conundrum, right? I don't think we can apply one therapy for every patient. And it also introduces the opportunity for the kind of studies that have launched so far, kind of platform studies that are exploring multiple different approaches based on insights gained from these biopsies at resistance.
And Ticiana, do you want to discuss some of the treatments that are out there right now that we're investigating for the various mechanisms of resistance?
Yes, and I do think that these studies are very important, but I think in the meantime, we're actually living this in clinical practice. And I think this is the biggest challenge right now because many of our patients are receiving osimertinib in clinical practice, and we're testing these patients, and hopefully we're increasing testing for our patients with resistance to osimertinib. And as you said, there is no standard, therapy beyond osimertinib, beyond switching patients to chemotherapy. But in terms of what options we currently have in terms of trials, we're seeing a lot of really interesting trials that are up and coming. One really interesting trial that we've seen is the combination of amivantamab plus lasertinib. This combination I found interesting because we saw recently it's called the Chrysalis study. We saw it at ESMO 2020. They are exploring this combination not only in the frontline setting, but also in the resistance setting. And the lasertinib is a third generation EGFR TKI. The amivantamab is actually an EGFR and MET antibody. And this combination is looking at patients. In this case, let's focus on the resistant patient population. So there's a cohort of patients who have received osimertinib and then have had progression of their disease on osimertinib, and then they receive this combination. And we're seeing 36% response rates in patients with osimertinib resistant disease with pretty good tolerability. One of the things that I think is important to note with the amivantamab is that it actually is an IV. So a little bit of a different sort of paradigm for EGFR patients or patients with EGFR non-small cell lung cancer is this combination actually, again, it's infusions, but a potential therapy that will have an impact in controlling the disease without going to chemotherapy. And overall, the treatment seems to have pretty good tolerability in a combination that I think is something that we want to hear more about for the patient population that has resistance to osimertinib. In that specific study, they actually also have a cohort with amivantamab as monotherapy for patients with C797S. So they are exploring amivantamab for the C797S population, as well as there are additional studies looking at different combinations. The Orchard studies that we are also talking about is actually kind of a more broad umbrella kind of study that is looking at different combinations, including looking at different mechanisms of resistance. For example, identifying MET amplification and then combining two different targeted therapy agents. For example, an agent that targets MET and an agent that targets the EGFR. So again, I think it's really going back and identifying and really personalizing the mechanism of resistance, and then really going back and seeing if that really is going to be a therapy that will make an impact in controlling the disease again. I do want to point out that chemotherapy is still a standard therapy. We saw in Empower 150 the addition of immunotherapy and anti-VEGF therapy plus chemotherapy with carboplatin paclitaxel, atezolizumab and bevacizumab, there was a small group of EGFR patients with TKI resistant disease, that in that small subgroup of patients, they showed that there was a benefit of this combination. And that was an early signal, I would say, of potentially a benefit there of this quadruplet combination for patients with EGFR TKI resistant disease. But I think we all want to see sort of a more definitive confirmatory study that would really show us that that would be a promising way to go, and for which patient population we would use that combination for.
So that leaves us a lot to think about. And Daniel, can you give us a more worldview on these combinations and these mechanisms of resistance and how you're looking at it?
Yeah. So, I do think that one of the challenges now with the use of osimertinib is really the unknown factor of, some of these resistance mechanisms, as well as, the extent to which they are actionable. It does appear that so far, some of there may be a small segment, a small proportion that may have actionable alterations. For example, we've seen the data with CMET, and perhaps some of the new drivers that have emerged. But even then, I think we've primarily seen small case series or case reports, and even in the presence of something like CMET, which arguably is one of the more actionable drivers, I think it hasn't quite the expectation of targeted therapy or combinations hasn't quite played out there. So I think a lot more to be learned about this what the drivers of resistance beyond what we detect as these mutations. I think the role of chemotherapy, as Karen had mentioned, it remains a very viable option, and I think a lot of patients do seem to be fairly comfortable with that, and I think part of this the discussion now in the patient journey is I do at various junctures now have the opportunity use that opportunity to discuss the option for chemotherapy and really try to see if there's how we can reframe that chemotherapy is kind of this very late resort that we last late option that we resort to after the rest of the therapies have not worked. So I think the chemotherapy-based approach still have a lot of mileage. I think it's worth mentioning some of the initial data that we've seen with the antibody drug conjugates, pretty new class of compounds for us in the thoracic community. But there had been also some again promising data using this HER3 antibody drug conjugate, where you have HER3 based IgG monoclonal antibody that's linked to a payload, chemotherapy payload with deruxtecan, and we've seen about 20 to 25% response rates in patients that predominantly osimertinib resistance. And I think it does speak to this concept that again expanding that repertoire, but that also underscores the importance of chemotherapy. I think this is the challenge of osimertinib resistance. It really sharpens that discussion, perhaps with regards to whether it's that even that choice of first line therapy, and just wanting to get back to that initial discussion, because I think when we initially have this opening discussion with first, second, and third generation EGFR TKIs, we talk about the more immediate kind of side effects, but and often it's a bit more difficult to have that longer term view about resistance. And I just wonder whether how that conversation and perhaps the patient perspective on this kind of landscape that we're kind of operating in now with the uncertainty with osimertinib resistance, whether that sometimes plays a different that element actually it should be factored into that initial conversation with patients and what the patient view would be. So I'm always curious about that.
So Sarah, maybe you could shed some light. I do know I've had conversations with patients, especially when osimertinib was newly in the front line. And when in the past, when we used drugs like erlotinib in the front line, we could say, and most patients, when they develop resistance, will go to the second pill, and that made them kind of happy to know that there was a second pill. And most people hear that these pills don't work forever. And so when we say that they're going on osimertinib, they say, what happens next? And that becomes more of a black box. And so what are your thoughts about sequencing that way? And what are some of your perspectives on some of the combinations and the treatments that may become available in the near future?
Well, I'm somebody who actually had progression on my first TKI. I wasn't expecting it when I did. And at the time, I resisted the switch to osimertinib because I thought, oh, I'm shortening my treatment options. I wanted to play it out as long as possible. And I was pushing to have an ablation of the spot in my liver. But I was eventually convinced that switching to osimertinib was going to especially as somebody who has a history of brain metastases, that this was going to really be, rather than put me through an invasive procedure like an ablation, it was really going to have a tremendous impact. And lo and behold, I was wrong. The doctors were right. And I've done very well on osimertinib, but it is, as I said before, it's the thing that we all expect and yet fear, that we are going to have progression on this drug. So the patient community keeps an eye on what's coming down the pipeline. And I have many friends in the community who have transitioned to combinations of targeted therapy and chemotherapy, who are, proceeding forward. There's not one clear path forward, but I know people who have moved on to all different types of treatments and are having varying degrees of success with that. I appreciated what Daniel said about chemotherapy, because I have had people come to me for, to run something by me and say, oh, well, the doctor's saying that my next step might be chemo and I'm not going to do that. And I think that's because there is still really a public perception of chemotherapy that this is, it's the end of the line. It's something to be dreaded. And, I tell people the chemotherapy of today is not your father's chemo. It's not your grandfather's chemo. There are so many ways that it is made much more tolerable than it used to be. And I know people who've been going for chemo infusions for several years and carrying on a normal life. So I like to point that out to people. And I appreciate that I think that's a challenge, I'm sure, for you when you're discussing it with patients, that there's a stigma about it and a resistance to that is, the harshest and the worst form of treatment, especially for someone who comes from, like I said, waking up in the morning and taking a pill in your own home. It's a hard pill to swallow to then have to be traveling to the cancer center for infusions on a regular basis, and all of what that might entail.
So maybe just to add on to that, I sometimes now also mention that, we are exploring chemotherapy as a frontline option in combination with TKI, and sometimes that gives some reassurance to patients that this is really something that, we're looking to see if there's really additive or synergistic benefit beyond that. And I guess one other point to make is that, from the earlier studies with the combination with other EGFR TKIs, I think the context of while the context of delivering chemotherapy upfront versus late after resistance also might be slightly different. But although I think it's still something that we really need to work towards trying to get patients more comfortable with the concept. Sarah, just also curious, what are your thoughts about Flora 2, with the whole notion of with combination of chemotherapy up front? I know you mentioned the convenience of having the pill, but in the context of what we know about resistance, that at some point chemotherapy may be deployed, is there a view that in that kind of context perhaps that we should the trials like Flora 2 it would actually be something patients wouldn't mind enrolling into?
Well, I think one of the things that, patients talk about amongst ourselves is, can there be a way to, if not prevent, then prolong progression? Because that is the thing that seems to be inevitable. And the longer we can, I'm interested in things that are looking at ways to kind of get at it from the, get ahead of the progression and target, if there are combinations that could target that ahead of time, which is going to delay the onset of it. Yeah, I think that's absolutely something that's palatable.
I think it's a strategy that is very promising, but I don't think it'll be a strategy for everyone. And I think we've learned that in lung cancer and in so many of the cancers that we really can't use a strategy that is the same for all patients. And I think that's the same for patients with EGFR. So I really am looking forward to seeing the results of using the circulating DNA escalation strategy as a way to identify which patients may need chemotherapy. So this is a strategy where they look at the clearance of circulating DNA at 3 and 6 weeks. And if you don't clear, then maybe you're the person that may need the addition of chemotherapy to your EGFR targeted therapy. So that may be a more promising strategy where you really are trying to identify, okay, who is the person that may need the addition of chemotherapy versus who can we actually spare from the addition of chemotherapy up front.
Mm-hmm.
So I think that would be, to me, most interesting as a strategy to try to spare patients who may not need chemotherapy up front versus those who really do.
Yeah. I think personally for me on a biological level, I'm a bit more intrigued rather than kind of chemo plus TKI by itself in some of the, and I think that one thing that wasn't clear is that these ADCs are actually targeted chemotherapy, right? It's not the same paradigm of a targeted therapy. You're just basically leveraging the EGFR expression to directly deliver chemotherapy. And so I think that that's a very educated type of strategy moving forward, right? Because in the absence of kind of small cell transformation, where we've seen across studies that people lose EGFR expression, no matter what resistance mechanism you get, there's gonna be higher EGFR expression in EGFR mutant lung cancer cells. And so hopefully one can, even in the resistance setting, leverage that, and you don't have to have as much insight into whether there's C797S, whether there's a MET amplification, et cetera, for something to be effective. And we've already seen that with preliminary data from the patritumab study, where there's responses across all of those heterogeneous resistance mechanisms. And I think in the upfront setting, it becomes an attractive type of study, although you do kind of sacrifice that independence because you have to come in for the infusions. But we're assuming that the reason that relapse occurs is that not every cell is equivalent, right? There are some cells there that are going to be the seeds of relapse. And if you didn't have to know exactly what was causing relapse, but you knew that they had EGFR expression, and you could double down on EGFR with an antibody of some sort or an ADC plus a TKI, it is an attractive thing to me that it could potentially prolong the durability of response. And that's our ultimate goal, as you have highlighted, Sarah, to keep the disease away as long as possible.
Absolutely.
Thank you. This has been an excellent, robust discussion. And I think the goal of prolonging progression-free survival, especially in the frontline, and having patients live longer, better lives. You know, when we first learned about EGFR mutations and EGFR inhibitors, we thought this was a miracle because for some of our patients, it appeared to be a miracle. And it's great, but at this point we can say it's still not good enough. And we need to keep working on the research, and we need people like you, Sarah, who are willing to be a part of the studies and your group, the EGFR resistors. We appreciate everything you all do because we need to improve for our patients. So thank you so much for joining this panel and this discussion on this case. We did put together some Journal of Thoracic Oncology references and other references as supplemental material. And I just appreciate your spending the afternoon with me today, or the morning.